get this terrible echo. Great. You ready to roll? Okay. Happy Friday morning. I'm Kelly Caseman, the Executive Director of Think Kids. Thank you for joining us for Including All Kids discussion with healthcare providers. I'm excited for this conversation today because we're going to focus on the ways that the healthcare system in West Virginia is improving for kids and families with developmental disabilities. And some of these efforts are led by the panelists that we have today. If you'd like to learn more about our project called Including All Kids, where we're studying the challenges to and recommendations for accessing and improving the healthcare system for kids with developmental disabilities, visit our website at thinkkidswv.org. Our agenda today is pretty simple. I'll introduce our panel and jump into some pre-prepared questions. I can see what you post in the comments below, so go ahead and post questions or comments and we'll get to them as the conversation progresses. So let's meet our panelists in alphabetical order. Dr. Beth Emrick is a pediatrician at Marshall Health, specializing in diagnosing and treating ADHD, autism spectrum disorder, learning disorders, and developmental delays. Dr. Jody Lindsay is the director of the West Virginia University Medicine Children's Hospital Neurodevelopmental Center and division chief in pediatric neurology. And Dr. Jenna Wallace is a psychologist with West Virginia University Division of Pediatric Neurology. Thank you all for joining us.
Thank you for having us.
Thanks. Okay, let's jump into question one. Let's discuss some background information. So all of you have been doing the work that you do for a few years now, and your training took a number of years. So what did healthcare look like for pediatric patients with disabilities back then?
So going back, to the start of medical school, I think is where I first started getting an interest. So you're talking about early 2000s at that time. And so our resources, particularly when I was training here in the state, were fairly limited, specifically from the healthcare standpoint. There were some state programs available to these families, but from accessing healthcare from particularly a specialty approach, and even beyond that, a multidisciplinary or interdisciplinary approach was very limited. And that really came down to limited resources. So one of the biggest things were there were very few pediatric specialists in all areas of medicine at that time. Through WVU Medicine, during my training, we covered the majority of the kind of primary pediatric subspecialties, but there'd be one or maybe two of those providers in each of those fields, which if you're covering the entire state's population and even some of our surrounding areas, that made the wait time to just even get into the available subspecialist very prolonged. And so difficult for families in that sense. And then in other subspecialties that may be harder to even recruit those providers because there's not a lot of providers going into those fields, particularly back during that time, almost 20 years ago now, we wouldn't have some of those subspecialties. So families would have to travel a great distance into larger cities or a larger hospital at the time to really access those services. I think the other thing was because there were few providers for the specialties that there wasn't the opportunity to really have that interdisciplinary or multidisciplinary type clinic model, because you didn't have the ability to staff that or have those specialists involved and integrated. So I think that is one of the major areas that I've seen dramatic changes from when I started my training here in the same area to looking forward to now. And practicing here for over 10 years as faculty is one of the biggest changes.
Yeah,
Thanks.
From a psychology perspective, I've been in the state now for about 10 years. And at the beginning of my grad school training at Marshall, I think the biggest contrast between now and then is just the expansion of health psychology and pediatric psychology. So like Dr. Lindsay was mentioning, the integration of psychologists into medical teams, which is an increase in access, right? And decreasing those barriers. So if a patient is going to be seeing their primary care provider, having somebody on site that can do developmental screenings or further developmental testing, working with families who have complex healthcare needs, at, learning coping skills and managing logistics. Those are things that I think really the biggest expansion in our state has been just that integration of care, and like with our healthcare team being able to see patients together for diagnosis and treatment has been something that I've seen a lot of. Whereas the traditional model of mental health was you go to that mental health center, you see that psychologist, you see that counselor or therapist, and then you have all of your medical appointments separately, which was really difficult for patients who travel a really long way to try to get this care for their kids.
Right, Beth, you want to jump in?
Sure. So I finished my fellowship in 2013. So for the first 8 years that I worked in the state, I was the only developmental and behavioral pediatrician. As Dr. Lindsay said, it's a common problem. Some of these are very small subspecialties, and Ohio, where I trained, actually happens to have a lot, but certainly a lot of the more rural states really only have a handful. And so for a long time, I was the only one. We're lucky to have a second now in West Virginia. And so part of what we're trying to do is build that capacity, and that's been happening in all the subspecialties, but particularly in people who are familiar with diagnosing autism and with, seeing these kids with developmental disabilities. So I think just continuing to build that has been kind of the biggest change over the last few years. And I think we're making some headway that way.
So quick question, Dr. Emrick, Dr. Lindsay, did you both grow up in West Virginia?
Yes, I grew up in Charleston, born and raised.
Yes, I did as well. Grew up, born and raised in Wheeling.
So do you feel as if you're still in the state because you saw a need back in the day and you wanted to come back and respond?
Absolutely.
That's actually, I hadn't planned on doing a fellowship when I went to medical school, when I was doing my pediatrics training. And my first year of my intern year of residency, I realized that was really a need that we had. And, again, something we didn't have in the state. So I wanted to go and bring that back home.
I had always planned to do some form of pediatric medicine after some of my work, and had really been interested in developmental disabilities, starting with some activities all the way back in high school. But I did go away out of state for my undergrad training and happened to be trained as a behavior technician for applied behavior analysis. And so when I'd come back on breaks in between bartending and waitressing, I actually provided respite care for a number of families of children with developmental disabilities, and particularly autism, and would help trying to work on some behavioral plans where these families did not have access to behavioral analysis therapy. And so really tried to provide some of those services. And I think that was the turning point for me, that I decided what field I wanted to do, but more so that I wanted to come back and create a system for those services for those patients and their families.
Well, we're glad you did. Dr. Wallace, you're not from West Virginia, am I?
Not originally. I'm married a West Virginian. But I'm a testament to Marshall and the approach that they took at training rural clinicians, right? That there was so much of an approach of, this is why it's valuable. These are the things that you provide to the community. I come from rural North Carolina, so I was able to really connect to that. But when I left the state, I also trained in Ohio at the end of my graduate school. I had no intentions of working in developmental disabilities. I hadn't had much exposure to it. There weren't many training opportunities in the state at that time for psychologists, and those have expanded, fortunately. But when I came to Morgantown, I met Dr. Lindsay. I had done some developmental disability things along my training, and her passion oozed over, right? And then we were able to collaborate and think about what this would look like in a way that we could continue to build these programs. So I think that that's something that's really important when we think about growing services in the state. Is it's not only about recruiting people to get here, it's about fostering that passion, helping people truly understand the beauty of our state and the importance of what we're doing. And then, like me, they get sucked in and they're really invested in how we're moving forward.
That's a great point. Thanks for sharing it. You know, we at Think Kids, I don't think when we started the organization, we thought about doing so much for kids with special healthcare needs. And we kind of transitioned into it when we saw just the overwhelming need. But there's also such opportunity for improvement. I mean, there are people like you all who are out there really trying to not just help kids, but try and change the system. And I think that that's really an opportune time to try and get more people engaged, build some social capital, get legislators involved in making some changes. Let's see. So we answered number 2. Let's get to number 3. How is the healthcare system adapting to meet kids with developmental disabilities needs? And is West Virginia keeping up with the curve?
So I'll start on that one. So I do think that the healthcare system is starting to catch up overall when you talk kind of a national level. I think really starting to build, like I mentioned, these interdisciplinary kind of multidisciplinary, depending where you're at and how they label them, clinics, which provides multiple subspecialties within one clinic. And that's not just your physicians or subspecialists or your APPs, but that includes our psychologists, that includes our rehab therapists, our social workers within a clinic. So really providing that comprehensive kind of model of care for these patients. So one, we know that access can be difficult, whether you're in a rural location, sometimes socioeconomic status to be able to attend and travel for those visits, or just the sheer physical ability to travel to those visits, depending on any physical disabilities that a patient or family members might have, and having other children, right? Large families and difficulty with childcare and jobs that become difficult for travel. So one, providing those visits that's easier access to all of those subspecialists in one, but also the model that it's providing true comprehensive care where the team is working together and thinking of the entire patient and how does one thing that somebody recommends maybe affect something else that's going on, and how best to provide a true treatment plan for that patient and family that makes sense and can work for them. So I think nationally, that's where most children's hospitals and healthcare models are working to move towards. It is sometimes a logistical problem to arrange some of those. And part of that depends, again, on the specialties you have and the staffing ability. Sometimes it can be space, can even be difficult that we navigate. And so really pushing those. I do think statewide, we are keeping up at this point. I think it was maybe a little bit slower in the past to get started, but I think over the past 5 to 10 years, we have really accelerated using that healthcare model. And that's not just within our neurodevelopmental clinics that we do or our child neurology clinics, but it's across all subspecialties, including the pediatric surgery subspecialties, which a lot of families, I know in some of our prior discussions and panels, had not realized was even available in our state at this point.
Yeah, there's definitely an information lag as well. You know, there are things that are building and the information doesn't even trickle down to other providers across the state of what's being done in different places, which is part of the nature of, Appalachia and the barriers that we experience. But I think one of the things that we all as health providers are trying to do, and especially during the pandemic, is get creative about how we structure our clinics, our wait lists, our different things that prevent patients from being able to get in. So we constantly are having think tank kind of sessions to figure out, like, how do we best get people in? How do we get them in as quickly as we can? How do we get them in the meantime connected to other resources, coordinating with Birth to 3, coordinating with the school systems, and communicating to families, and even saying, like, we know this is a wait list, and we're sorry, how can we help you in the meantime by doing some of the telehealth that we're doing too? So I think that with the pandemic, although it was very stressful for all of us as healthcare providers, and continues to be. We've used that and leveraged that to think about our processes and how we as a whole hospital system, as a whole healthcare system, can make things more accessible to patients and alleviate some of those burdens. So some simple examples would be for us doing telephone intakes prior to patients coming in for testing appointments, so that there's not the lag of the child having to sit there for an hour while the parents talk about them, and also not the lag of insurance pre-authorization for certain types of testing for psychologists, integrating our appointments together, which we were doing before the pandemic, but ensuring that we're giving patients resources when they walk out the door instead of having to wait 2 or 3 weeks for our reports to come. So I think that's been an area that is harder to measure, is the kind of thinking that and evaluating that a lot of healthcare providers have been doing to try to make this better for families.
I want to touch on one thing Jenna said, kind of related to the pandemic, about getting kids in for sort of the services outside of the medical system. So certainly Birth to 3 is a huge, really important resource in our state. And one of the ABA therapists through Kanawha County Schools told me that they are seeing kids coming into school and kindergarten, basically, who haven't, they didn't get those kind of preschool services, but they also didn't access Birth to 3. And a lot of that was because of the pandemic. So I think as primary care providers are seeing these kids, they really need to make sure to help kids now that we're sort of, hopefully, at least we have the services available, and maybe we're still having the pandemic, but making sure to get those kids connected as soon as possible, even in the meantime, while they are kind of getting in for their appointments to come up with a diagnosis.
Yeah, that's so important. I see, for me, I see this shift, and it's something that came up during the roundtable, as you'd mentioned, that we had parents who said, I have to go out of state, and these out of state hospitals, they're like this hub where you can get all this different care. And instead of me having to go 4 different places, I can go one place. And this parent had no idea that that was actually happening here in West Virginia. And, I think that hospitals certainly mean well when they try and share information about the services that they have available, but they have a tendency to do it in a way, in my opinion, that isn't really intuitive for parents. So, from what we've heard, a lot of what parents do is, they get a diagnosis, or they're told to go get a diagnosis, and they just start Googling, or they get on Facebook. And they don't get the information that they need to get from point A to point B. So it gets very, they start relying on people who, don't know what all is going on in the state. It would be so much easier if we had kind of a touchstone, a centralized point in the state or online or social media to help direct families. But, even I'm thinking of what Dr. Emrick just said about having those providers who are in the know, who can refer kids to care. Now, it was only just a few years ago when I had a parent of a child with autism who said, I had a primary care provider who told me to just go ahead and wait until my child started kindergarten if she was still exhibiting, because she may grow out of the symptoms. And if she still did, then they have services in school not to worry about it. And so we seem to have some really good stuff going on this, with what you're doing, but there's that information lag that we really need to address to make sure all parents have access to what is going on, the benefits of having this hub of all of these different providers, and, what are next steps if you need to get connected to, services close to you.
So to touch on that, some of the upcoming ideas and planning through Children's at WVU to provide better access to that has been, because that's been part of our discussion as well. How do you disseminate that information so they really do know what's available, right? Just saying you have a spasticity clinic, well, what does that mean? Who's involved in that? And so we're hopefully making a push to start with these nurse navigators that could be accessed. So either families could contact them through like a health line, or providers, referring providers could, to discuss kind of the patient and what resources they're looking for. And that would be a point of contact that would be aware of what's available throughout the state. Also becoming hopefully more accessible as WVU Children's and Marshall has this collaboration with the children's hospitals. And so again, kind of an ease of information of what's available and how to best get patients put into those kind of right pipelines, like you mentioned. Some of the other things that we've talked about also, and has always been one of my main concerns, is we know the best method of providing kind of overall comprehensive care for a family is a medical home, right? And that's always been discussed. And there's one thing it's not changed from an understanding level of when I trained to now, is that we know that model is what works best, but it's really difficult to create with how medicine operates these days for these families. A lot of our primary care providers are overwhelmed, right? They have a lot of patients, and things that have changed in the background with medicine overwhelms them. And so it becomes harder to be that medical home. And as medicine has become more complicated and we understand more, but we've become more subspecialized and more treatments, that again puts a lot of weight on the medical home shoulders in understanding that. And in truth, in medical training, one of the areas I feel that is still lacking is training for providers across the board in developmental disabilities. Now, us sitting here today, because that's our area of practice or a primary area, we've received much more training than other providers. But I think that's an area that could really be improved in medical training still, so that we could make those providers much more comfortable to be that medical home. And I think some of that responsibility comes on us in the field, right? And so that's one of my hopes as we continue to grow throughout the state and surrounding areas, is that we could start to provide resources and training, not only for generations behind us to continue the work and care that we provide, but really to provide some of that training and level of comfort to our primary care or medical home providers.
Mm-hmm. Yeah, we did a project this past year of assessing provider knowledge, but then sending them our resource packets. And it's just the simplest thing of, if you have a patient that you are concerned about or that might need these services, this is the statewide resource packet, just give it to them. You know, we are not the keepers of all knowledge, nor do we want to be. We want everyone to have this information and knowledge. And so when we get the opportunity to speak to providers, to do grand rounds, to go out into the community and talk to schools or whoever it may be, we are so happy to do that, because we know that we can't provide every single service to everyone, but we want to put information in the hands of people who are, touching patients every day or every step of the way. And then the other piece is that parents have contributed a lot to the increase in kind of knowledge about services. There's a Facebook page in Morgantown. I'm sure there are some in other parts of the state too, where families, or like Moms of Morgantown, just general Facebook groups where families will say, where can I go to get access to this? And parents are so willing to help and support each other through this. And it's just amazing that at least that benefit has come through the digital age too. It's just people being more connected to one another and willing to help each other. So we can't understate how much parents are doing to help this move forward.
And this is not specific to children with developmental disabilities, but certainly just the mental health crisis overall. In the fall, the American Academy of Pediatrics, the Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association nationally declared that we're in a national emergency for mental health. And this is Mental Health Awareness Month, and certainly affects our families and children with developmental disabilities, but as well as, all the kids in the state. And so our pediatricians and family practice colleagues who are taking care of these patients every day are facing this. And so they are trying to get a lot more comfortable with managing some of these things until they get into services, or again, just because of what are the things that they could manage in that primary care setting. So I know a lot of them have been kind of seeking out more training through conferences and institutes and things like that to get other help being comfortable to treat those mental health problems, to take some of the burden off of those families too.
I think everything y'all are saying is so important, especially when we think about, we don't have a robust network of pediatricians in the state. Hopefully that will continue to improve, but we still have kids in rural communities who are being treated by general practitioners who don't specialize in pediatric care. They don't, their professional development isn't in kind of the area of pediatrics. And so it's just ensuring that that we permeate the market of, we don't expect you to know everything, but if you need to know something, here's where your resources are in the state. Especially when it comes to mental health care. We don't have the data in our state, but I don't know how many kids are showing up in our ERs. But I know anecdotally from people I know that we have an increasing number of kids who are going to ERs, staying for many hours, and then being turned away because there simply, aren't services for them there. So that's a good segue to the next question. In terms of common medical diagnoses, has treatment changed for kids with special healthcare needs?
So when you talk about their common medical problems, so say taking a child with autism who may have a low grade temperature and it's pooling at their ear, right? And so the parent's concerned about an ear infection. I don't think our overall management or recommendations of how to treat that has changed, but what I do feel has changed, and we've gotten some groundswell, is the way we help that child in starting with the evaluation, bringing them into clinic. Now, is that occurring everywhere? No. And unfortunately, we heard that, I think, in some of the prior panel discussions as well, right? Of an understanding of general care providers such as urgent cares or emergency departments, maybe in more rural areas or areas that are smaller hospitals, and those providers' comfort levels and understanding of the best approaches to get the information you need from either the families or in evaluating the patient, so then you can provide the right recommended treatment. I think in areas that we have more of these programs developing, that has changed. But again, I think there's a lot of room for growth throughout the state and kind of surrounding areas and how we do that. I think in specific treatment of recommendations for treating things associated with their diagnoses or their developmental disabilities, that has dramatically changed, right? We know certain things in the past that are still kind of gold standard or most evidence-based treatment, but I think access to those is improving. Again, not where it needs to be for everything, but is improving. And I think knowing that those are necessary treatments and that being spread and understood throughout a large number of providers has significantly improved. And the understanding that we don't wait, hopefully, right? And that we do push for early interventions and treatments for these patients is really starting to improve over time.
I think it's improving, but it's also a little bit still kind of area dependent. So I would say there's places certainly in the southern part of the state where, you really do have to come to Charleston or to Beckley or somewhere like a bigger city. So still trying to reach out to those kind of more rural places is important, but it has come a long way in the 8 years or the 9 years almost since I've been back in West Virginia.
I agree. I'm going to read a comment from Alino Danko. As a PI for the West Virginia Family Health Information Center, I'm very interested in working together to develop that online hub to guide families to learn the services to navigate. Great. That's wonderful to hear. I think, there seems to be autism, for example, just over the last 10 to 15 years, it seems as if diagnosing seems to be, at an earlier age. seems to have really changed. And I think you're right. It's trickling down kind of these medical advances to our more rural parts of the state, to those providers or clinics that aren't kind of connected to this dissemination of information is key. But again, I think that West Virginia itself, we're really kind of adapting and growing, and it's trying to create more of a strategic response in that growth. The West Virginia Developmental Disabilities Council funds a project we've worked on for the past 3 years. We've completed 3 surveys with parents and caregivers of children with developmental disabilities. I'm going to highlight some prevailing themes, some that you've heard before, and open the floor for any thoughts, comments, or work you know that's underway to address some of these challenges. So, number 1, accessibility to healthcare, especially specialty care, seems very dependent on where you live in the state. Y'all agree?
Yeah.
Yeah.
Yes.
And so I think that speaks to what Dr. Emrick just mentioned, is that we do know, certainly in the areas surrounding the larger hospitals, particularly the 3 centers that do have children's hospitals, right? So WVU Children's in Morgantown, Charleston, and then down in Huntington with Marshall, there's pockets of a lot more resources available for families, particularly when you talk about not only the medical providers, but when we're talking about the therapies and recommended services, so things like ABA or the pediatric specific speech, physical therapy, occupational therapists. When you start to get in some other areas of the state, it can be limited. It is starting to grow, particularly as some of these university hospitals that we're discussing are acquiring smaller facilities in various areas. We're starting to get some more resources into those areas as well, like looking at the Eastern Panhandle and those type areas, Wood County, kind of over in Parkersburg. But it has still been slow. And those numbers of services, even though they may be available, it's not the number of providers needed for the number of patients and families that need those resources yet. So wait lists tend to still be very long. And, the child may be hitting school age before they're able to get off of any of the lists to receive those services.
Right. I do think this is something to discuss. We have these large hospital networks, right? So WVU Medicine, I believe Marshall Health, you collaborate with WVU Medicine, you collaborate with CAMC, and there's opportunity there because you have these networks that are created larger and larger to help navigate families who are diagnosed in these smaller communities to services in the state. And we talked about this during our roundtable last year. There are also the benefits of having kind of this medical history, like an electronic health record that will stay connected. Can you speak to that a bit?
So it is still difficult between the 3 facilities in the state that you just mentioned, because they don't necessarily connect with their programming that they're using. I did mention, I think in the former roundtable that you're discussing, WVU Medicine utilizes electronic medical record system called EPIC, which a lot of the other children's hospitals that the families were referring to in that roundtable also utilize. And so through that, there is something called Care Everywhere, which if a patient's seen at one of those facilities or seen here and then goes to one of those, we can access those providers' notes. We can see the imaging results from the reports. We can see lab results easily in that system. I do know that there was talk and some work underway of trying to merge the systems that may not be the same computer EMR system, but still a way that information would be able to be accessed. There are systems in place already, like for instance, if a patient has imaging done at one of those other facilities in the state, it's loaded into a database when permission's given by the patient. So if they're transferred up here or transferred down to one of the other facilities, that provider can see that imaging. So there is work underway for that to be connected, but not all systems are there yet. It would be nice if nationally, everything connected. And so you would feel secure. And if you're traveling, okay, they'll have access to all of that. There was work years ago before all of these systems were able to share through EMR, that people would carry jump drives. There were projects that were sponsored that carried all their data. The problem is you have to worry about updating that constantly and carrying it around. So having something that's much more accessible and just easily shared has been the latest push.
It is nice that a lot of the EMRs have that patient portal, and so the patients can have access. So even if I'm seeing them in clinic and I don't have the records necessarily from Morgantown, let's say as an example, the patient can pull it up. I actually had one who just pulled it up for me and I read the note on their little my chart, so that's really helpful. I would say the other barrier, and sometimes having that data, is children who are in foster care, who are adopted. The families don't always get a lot of that medical background. And unless they happen to have been born in your system, then you don't have a lot of those details, particularly like birth history and things like drug exposures and things like that. So we have as much as what the parents have, and I think it's really important for that to be shared.
And along the same lines of technology, the use of telemedicine, I know, can be anxiety provoking, especially for parents of children with special needs, because there is this thought, and in some cases it's correct, that like you need to physically be there to see my child and touch them and make sure they're okay. And a lot of the things that we do as far as, counseling with families about their child and talking them through school situations and other things can be done in this modality, as long as they have internet access, which we again know can be a really big barrier in our state. But I always encourage families, especially those who are experiencing mental health crises and have a hard time getting to therapy for their kids or have a hard time accessing care, that you can use telehealth. And telehealth for medicine and for psychology has been used for a very long time, even before the pandemic. It's not something, it was all new to a lot of us with the pandemic, but it's been studied to be evidence-based when we think about treatment for a lot of psychological disorders. And so if you find reputable people that are away from you, but are in some of these hubs, like in Charleston, Huntington, and Morgantown, give it a try, and it's better than nothing, right? It's, even if your child can't be here with a psychologist on a weekly basis, doing telehealth therapy might be what you need to hold you over till you can get in person with somebody, or it might be exactly what your child needs. So that's always my plug, as to the technology's nerve-wracking at first, but some patients really love it, especially adolescents.
So that's kind of a good segue, that interaction to the next prevailing theme. Interaction with primary care providers can be very positive and constructive, or short and frustrating. Parents and caregivers express that they felt unheard, rushed, or dismissed.
So that's a tough one, I think. And that kind of goes after a little bit of what I said. So the pressures put on some of these primary care providers, right? Which in some of our areas, there may be one covering a pretty widespread area, right? And so the ability to see and care for all those patients in a timely fashion, our hope as providers is that we always provide whatever amount of time it needs to get the appropriate information from that patient, make them feel heard, make sure they understand what we're recommending and what we're hearing from them. But that can be difficult a lot of times. And so I think certainly increasing overall access to medical services in the state, which really means continuing to increase our provider numbers, is a really big deal and not something that should be forgotten. We pushed that for a number of years, particularly around the time back when I was training. And there was a really big push, particularly to get providers to go into some of those primary care fields, such as general pediatrics, family medicine, OBGYN. And then there were programs to support individuals to stay and practice in those areas, right? Like medical loan reimbursement and those kind of things. And so I think it's really important that we continue to advocate for that. And that is some of what we're pushing to do, even outside of just physicians or psychologists, is that There are programs that entice and try and recruit individuals to provide things like ABA therapy in these more rural areas. And so we're working with lobbying and advocating legislation for loan reimbursement and incentives for providers to stay for things like rehab therapies and those type of things in these areas, because that has been the most difficult thing to really get those resources. But back to specifically primary care, I think the other main thing that you had mentioned with those shorter visits is I think it's important for patients and families to always feel okay that they need to be their child's advocate. That's being a good parent, right? And then the best provider never sees that as a negative, right? And so I think sometimes if you're feeling that way, not hesitating, and I understand it can be hard, but saying, wait a second, I have more questions, or I didn't quite get this, or can we spend a little more time on this, or asking to come back for a sooner visit. That's okay too. You know, we always talk about just the patients we see. We give a recommended follow-up time, but we tell them for sure, reach out to us. You don't have to wait if you have further questions or something comes up before then. Contact us. It may be something we can just call and discuss with you. We might be able to do a quick virtual visit to help with that, or it may be something we want to bring you back in sooner for a big visit. And so I would tell families never to hesitate to just speak up and be that advocate for their child. We would hope that they don't have to do that often, right? And that they feel secure in the care that they're getting all the time. And that's not something that's needed frequently, but I think that's an important thing to remember.
Yeah. And it can be really nerve-wracking. It can be very anxiety-provoking to, especially when you're in a situation where your pediatrician or family medicine doctor kind of has more of that approach of, you know, I'm the professional and you're the patient, right? We've all experienced that. And going in with a plan in mind of the things that you want to ask, like Dr. Lindsay said, being assertive, and recognizing that doctors are a lot like people, in that sometimes you fit well with someone and sometimes you don't. And we know that patients don't always have the luxury of saying, well, I'm going to go see this other person, because there may only be one person in your area. But if you're able to, you know, seek a second opinion about developmental kind of things, that's okay too. But we do hope that patients will be able to be assertive with their providers and have that relationship. But we know that sometimes you got to find somebody who fits better for you. And it's hard. It's really hard to be a parent of a child who has any kind of special needs, especially in a state that's under-resourced.
And I think the primary care docs are trying to do a lot in those very short visits, right? So it's summer now, so we have to counsel about water safety, bug spray, sunscreen, but then also listen and make sure that, you know, the family's concerns are being addressed. So as Dr. Wallace and Dr. Lindsay both said, I think it's just important for parents to make sure that they speak up and call back. And if they don't feel like they got what they needed that day, if they go back and think, oh man, I wish I'd said this, call your doctor and let them know, or make another appointment to follow up and discuss that concern specifically.
Yeah, absolutely.
Thanks. So it leads into the next point. Families lack a support system, especially when receiving an initial diagnosis. So if we were to try and build a more robust family support system in the state, what first steps do you think we should take?
So I like the model of that central hub that starts when a primary care provider or even a family member has concern and they're seeking referral to maybe one of our clinics, Dr. Emrick's or mine or Dr. Wallace's or our teammates, for evaluation for a potential developmental disability, in the sense of just giving them initial information of, okay, this is how the referral process works, right? So our staff, once we receive the referral, we try and make families aware, for instance, that we have an intake process, and there's a reason behind the intake process. It's because we need that information ahead of time to assess what type of assessment do we set you up for. And we're trying to make it so it's a limited number of visits, and we can do it potentially all in one. We also need some of that preliminary information from other settings, such as schools or from therapists and things, to help in making certain diagnoses. It's actually a requirement when you're evaluating clinically that you have information from multiple settings. So that's really important. It's also important if we're trying to time and combine psychological testing as part of that evaluation, because insurances require prior authorizations a lot of time for that. And if we don't have the information up front, we can't obtain that. And so there's reasons behind kind of our intake and initial referral processes. And then we try and also inform families of what we know our wait lists and wait times are, but also, as Dr. Wallace mentioned early on, of, okay, this is the wait time, but here's the things in the meantime that you have access to and can get rolling. A lot of times families are under the false understanding that, well, we shouldn't contact birth to 3 to get therapy started until we get a diagnosis and assessed by you. And that's not true. Most of the time we tell families that therapies look very similar in young children, no matter what diagnosis or underlying cause we think is leading to those delays or behavioral issues. And so really trying to give them good information from the start that no, it's okay to access these things first while we're getting everything else kind of set up and worked up. But then I think also then we spend a lot of time in our visits afterwards, and our visits tend to be very long because we're trying to provide the family with all the resources we know about at that time, because we know it can be difficult, but it's a lot at that visit, right? A lot of times families just shut off as soon as you give them a diagnosis, and it's hard to process those next steps. So we provide it kind of in paper form, and we tell them we're here as a resource to call and help with. But I think a system where we had good follow-up after, and so that would be kind of one of those navigators, whether it be a nurse or a social worker, who's easy access for these families to kind of circle back and say, well, how did you process this? Where are you at in accessing those resources that they talked about? How can we help you with some of the hurdles to do that you're running into? And that's part of the programs we're still pushing to develop and organize. And I think if we could have something that's more statewide based, that's even easier access and understanding for the families of, this is who I go to kind of get that information, I think that is a perfect model.
We always feel really lucky when we are working with a family that's already connected to birth to 3 specifically, because they have their care coordinator. And at least a lot of the ones that we work with, we say, take this letter to your care coordinator. They are like the experts in your area, and they really do a phenomenal job working with them. Same thing with the early Head Start coordinators. We've worked with them to talk about, what a family's going to hear from us at that visit, and then what they can do to help support them. But it would be so wonderful to have a statewide system of social workers, care coordinators that are available, almost like a hotline that families can call and say, I don't know what's happening. Now, we do refer a lot of patients to call Marshall's Autism Training Center and the Center for Excellence in Disabilities here at WVU, because they are both phenomenal hubs of information and have a lot to share with families. But it would be really nice as a state just to say, like, this is the person, the contact person or people that can help. And for them to have follow-up calls following diagnoses would be great as well, because sometimes families don't know what they don't know yet, and that's okay.
And that's hard. I think sometimes when we make a diagnosis, they're listening and they're trying to understand, but like Dr. Lesley said, sometimes it's just shut down. They hear that word, and even if they were expecting it, it can come as a surprise. And so, making sure that they know that they can call back, but then having a resource that would say, like, okay, maybe I didn't fully understand this, or what does this really mean? Or what do I do next? Even though we're giving them a lot of that information in that moment, they need a chance to breathe and reflect and sort of take it all in before they can really access it in their mind, probably.
And I'd say too, that like sometimes we do a really good job at providing that information, but we're assuming that English is their first language, or that the information we're providing in written format is easily read by the family. And that is not always the case. And so then the onus falls to us to provide those interpretation services in whatever way that we can. And that is not a resource that's easily accessed in our state either. So having that where we're able to, if a hub is able to translate into language, or in, simplifying written documents into language that's easily read by families, that would be, invaluable.
Completely agree. It sounded like, through our surveying over the past year, that it's kind of like the tale to diagnosis. So you get, somebody heard, a mom who heard really kind of a devastating diagnosis, but she was walked through, your son will be okay, but the life he's going to have is not the life that you thought it would be. But it still can be a quality, you can still very much have a good life, and then walked her through the process, as opposed to, we had a number of written responses through surveys of parents saying, I got a hard diagnosis, I got a pamphlet, and I was, kind of pushed out the door. And I didn't feel kind of that kind of safety net of everything, it's not going to be the same, but it will be okay. And so I love this idea of, if somebody feels as if they're kind of floating without some sort of support, that they would have a number, and at least somebody can start walking them through the process, identifying if they're not able to, have the level of reading comprehension and can help them understand and break it down. I think that would be really a great resource to have. I think maybe a next step for me is to see if there are other resources like that in other states.
Yeah.
So let me see. I think we have 9 minutes left. So let me see what questions we may want to discuss before we go. During an interim committee meeting, I presented to legislators an idea from last year's roundtable that we create a centralized website on the Medicaid website that lists all pediatric specialty care in West Virginia by county. What are your thoughts on this? And then that's a good segue to talk a little bit about Medicaid. So I think we're all in agreement there has to be some centralized information, but not all services in the state are covered by Medicaid. So is that a logical place for that information to be?
I think that's hard, right? Because I think you're correct. Not all patients are covered by Medicaid. And so I think it's probably more a system that is able to be accessed by all the healthcare systems. Who's the actual owner of that, I think, becomes more difficult. And I think it really probably comes down to much more technological question of how can you just make all of the systems potentially interface. So the owners of that information are really where the service was provided, but that these other providers have access to it and the patients have access to it, right? No matter what the EMR system is, the large majority of them have a patient portal option, like Dr. Emrick mentioned, right? So the patients have direct access to their own information, but they also, the other providers from different systems would have access to it. I do know that becomes somewhat of a, like I said, a technological nightmare sometimes to make systems kind of combine and talk, but I think it's getting to that point. And I know that's been done where there's been a mix of other EMR type systems.
And as far as keeping track of like what resources are available where, which maybe I was kind of thinking we were talking about, but I think it does seem logical for that to be somewhere as a statewide system, and maybe Medicaid isn't exactly the right place because other people with other insurances might not think to go to that website to look for where those resources are. But I do think that somewhere as a state as a whole should have something for that. So I don't know if that's on the DHHR website or maybe the Developmental Disabilities Council website or something like that. I think it is tricky of where to put that, and how to keep that updated to make sure that it's accurate and what's available is still available. And as new places and new providers arise, that they are included there.
Yeah, I agree. That's one of the hardest, I think, because we provide, and like Dr. Wallace mentioned, we share with anyone that we partner or team with, but provide to families kind of a running list, for instance, of resources when we diagnose a child with autism. And we have it broken down into kind of multiple areas in the state and lump those providers, and then even surrounding areas in other states we've included over time as we've seen patients. But it becomes hard. And we tell families, this isn't all encompassing because we don't always know if a new provider comes in. We also don't know always when a provider has stopped seeing patients because their list is too long or they've cut back. Or sometimes it's a delay in us even knowing they're no longer there and providing services, right? It's also hard too, because we're not a governing board, right? So if there's complaints or issues with a certain provider that's not directly part of our health system, we're not necessarily aware of that. And so we warn families that they are providers that we provide information to who we have gotten feedback from or who we personally are aware of in some cases. But again, the one place I would think about would maybe be a combination that it comes out of some of our licensing boards. That would feed into it. The only problem with that is if you think about one of the biggest resources that's needed in the state, particularly when you talk about autism, is ABA. And that's been one of our discussions is we don't have a licensing board in the state for them. There's an organization, but a BCBA does not necessarily have to join the state organization and be a part of it. And so there's been talk about trying to set a licensing board for them. And that's actually a group of providers through the Mountaineer Autism Project that I'm working on, one of the initiatives that we're considering in a strategic plan, because it affects a lot of those things. But one of my thoughts would be maybe doing it out of our licensing boards for us various providers, because they should have up-to-date knowledge of new providers coming in, applying for licenses, and when providers are no longer providing services in the state.
Yeah, there are national websites like Autism Speaks, for example, where you can submit as a provider who works with patients with autism, your name, credentials, information to be on a hub like that. So, it could even be provider initiated, but I do think that going through the licensing board would be the best way to keep it up to date, comprehensive, and to ensure that if there are red flags, if there have been investigations, that patients can then access that more easily.
I agree. I had a couple of conversations after this was discussed at our roundtable last year, people saying, how could you keep up with, whether or not they're accredited, what if there were some red flags, who removes them from the list? I think that there are a lot of caveats and concerns to it, but I still think it's a really important thing to do because we want to make sure the parents and families know that there are resources out there, because that seems to be the number one problem, is that they just don't know. And then they get pointed in out-of-state care that is really, costly. It is time-consuming, and for some families, they may thwart, getting that important care because they don't think that they can afford it. So, yeah, I think it's something for further discussion. I want to hit just a couple of points that were mentioned on YouTube. CED said that family-to-family program could be that centralized information. That sounds wonderful. We'll need to reach out to them. And Melina says we have 2 programs at CED where parents can help other parents navigate and process. We're looking at developing a volunteer parent mentoring program soon. And I think that sounds wonderful because I think it was you, Jenna, and I completely agree that there's a handful of parents in this state that are really upholding and doing a lot of this work that we're talking about, and they're doing it for free. And I talked to one a couple of days ago who I think is also a little exhausted because not only is she hearing about information that she needs to share, but also advocacy rights and hearing things that then she feels compelled to really help with. And I think that's something for another discussion for another day. So having said that, we've got 2 minutes left. Is there anything that we should have discussed that we didn't get to that you want to touch on before we go?
Since you mentioned advocacy, it kind of triggered in my mind, families, your stories are the most powerful agents of change that we can provide to legislature. When you have an experience, share it with your legislators. Reach out to them and say, my child has autism, my child has Fragile X, my child has cerebral palsy, and this is the situation that we face on a daily basis. We have to drive 2 hours to see our providers, sharing that information, sharing it with us, sharing it with Kelly, with the CED, with everyone that we can use as compilations of stories. Those are the most powerful things that we can do to make change, because as much as we all are working to improve our processes and expand access, we are only single people in ourselves, and we are trying to work together. But when parents are involved, you guys are the ones that are doing really hard work out there. And the legislature needs to know all the things and the hoops that you're jumping through.
And the point I would add to that, which I think is perfect, is also sharing the good stories. So if something has worked well, really sharing that with individuals and legislature and medical systems, because it helps get us support for programs to continue to grow. Because our intention for all of us here talking today is really to not only take what has already been built and expanded, but to grow that throughout the state. We want access that's local and easy for all of our families and patients. And the way to do that is really to have the support behind us, not only from the state, but from some of the health systems. And so when they know what's working for families and that it's a good thing, that helps gain that support as well.
Agreed. Dr. Emrick, would you like to have the last word? No pressure.
I actually think that Dr. Wallace and Dr. Lindsay summed it up perfectly, but I think really those personal stories really hit home with the legislators, and that's, personalizes it for them, and those are their constituents. And so that's going to help them really fight for what we want them to fight for.
It's a great ending note. And I will say that over the last couple of years of working on this project, I think that there are a handful of legislators who are very interested in learning more, hearing about the challenges, what's working, and trying to support those things. So the time is really right to try and do, build some social capital, go to legislators and give, very specific steps of here's the way we can improve or build on what we have. And so if anybody is watching and wants to get involved, they can contact us, they can contact the CED and see if we can get better at elevating and articulating those needs. So with that, we're at the top of the hour. Thanks to our panelists, Dr. Wallace, Dr. Lindsay, Dr. Emrick, for all of those who watched, the West Virginia Developmental Disabilities Council for funding the project. If anyone has any additional questions or comments, they're welcome to continue posting on the comments section. We'll keep an eye on those over the next few days and shoot us an email. We'll respond to that as well. And we'll post links to the panelists' organizations and programs discussed during the conversation. So with that, thanks again. Have a great weekend and Memorial Day.